So we are talking about PCR management, a situation which most of the interior segment surgeons dread. They would rather that this should not happen, but if it happens, they should have an option to manage it so simply that the fear out of a PCR goes out. So over a time, we have developed some techniques. We have been using it regularly in our system. Dr. Alka here, working with us, now knows that we have something which is called a PCR kit. The moment there is a PCR, we open the kit and start working. So I'll take you through this process. Maybe you'll find some tips which are useful in your routine practice. And to start with, a small introduction. So the moment you notice a PCR, I'll keep the volume down. Now a PCR has happened, so the first thing you do is you fill up the chamber with viscoelastic. That is the first immediate reaction. And then you relax. And then you set up your system around the eye. So use a IV drip attached to a bottle height which is just 24 centimeters. 30 centimeters is 1 feet, 12 inches. 24 centimeters is about 10 inches, just this much. This is the bottle height that you need so that the IOP it maintains in the eye is 18. And then you use a vitrector. Vitrector in the IA cut mode. If you have vitreous there, then cut mode first, remove the vitreous strands, then come down to the IA cut mode, where the foot paddle 1 is irrigation, foot paddle 2 is aspiration, and foot paddle 3, Utte aaja na, itte aaja, yeah? Aaja, you can be part of a discussion. And foot paddle 3 is cutter. So here, when I am removing these cortical pieces, in foot paddle 2, it is working like an irrigation aspiration system. And the moment the cortex material is engaged, I go to foot paddle 3, and in the cut mode, I cut out the cortex along with any attached vitreous strands. So I don't have to like remove the cortex, then again come into the eye, do a little cutting with the cutter, then come out, use an IA to remove the cortex, then the vitreous is disturbed, then again go in with the cutter, cut. So everything is taken care of with this cutter. Once I enter the eye, I finish the cortical aspiration with any attached vitreous strands and come out. I'll show you how simple is it. So the next point is, this is the system. A normal IV stand, we are all used to keeping the IV stand at this level, bottle height of 100 or 90. Now it's very difficult to conceptualize that in this case the bottle height, not here, let it fall down to the bottom of your stand. And the height is measured from this level in the drip set to the eye. And this has to be just 10 inches, just 10 inches. Eye to here, you can hardly make out ki bas itna sa, itne mein kya hoga. This is giving you an IOP of 18, which is the physiological IOP that will keep your eye inflated at all times. Will never let the chamber collapse, will not hydrate the vitreous, and you can move in and out of the eye comfortably at all time without worrying कि मेरे को पहले visco डालना है या fluid डालना है, then I bring out my instruments. You have to forget about all that. Focus on the vitreous and the PC rent, and not these small things which you have to do simultaneously when you're handling a PC rent with vitreous. Right? So this is the scale which tells you bottle height 24 gives you an IOP of 18. And when you have a bottle height of 88, 90, which you normally have, and you don't lower your bottle height when you have a PC rent, your IOP is 65. तो naturally जब 65 होगी तो इतना प्रेशर होगा आई के अंदर that it will churn off the vitreous. You want a physiological IOP 18 कि vitreous नीचे पड़ा है and the pressure is such in the eye that there is no vitreous disturbance throughout your surgery. Right? This is the crux of the whole management. Let us see how this works. So, the second thing, first thing is the bottle height. Hi, Dr. Rohit. Aja, upari aja. Welcome to Dr. Rohit, another prolific phacosurgeon and a lot of experience with complicated situations. So, how the second thing, which is very important. The first thing was the bottle height, which has to be at 24 centimeters, that is 8 inches. And the second thing is you need an anterior chamber maintainer attached to this bottle, which is going to keep that perfusion in the eye continuously from another port. Now for this, we have devised an anterior chamber maintainer which is slightly different from all the anterior chamber maintainers which are there in the market. All the ACMs in the market are the ones which open from the tip. If you use that ACM, the fluid will go and hit the vitreous. It could churn up the vitreous. We have kept the tip blocked and the fluid comes out from the side as it comes out in a bimanual IA system. You have the tip blocked, no? The fluid is coming from the side so that the fluid is not disturbing the central area. It's just oozing from the side very softly. The central area does not have the ripples that you would expect and get disturbed by. Okay? So, you no need to fill the AC with visco every time we move in and out of the eye. Maintains physiological IOP at 18, preventing or reducing vitreous hydration, swelling and further prolapse of the vitreous, right? Now, you are ready to handle situations. One situation is you have a PCR with residual nucleus. One situation is you have a PCR without residual nucleus. So, let's go one by one. Let us first say without residual nucleus and see how we are going to manage this. First situation, PCR, this was a posterior polar, a PCR. In the center, I came out just like that, not a great idea. The vitreous had prolapsed. I have put in an ACM, and you see, whenever there is a vitreous, it will always move towards one of the ports, one of the side ports or one of the main ports. These are the only three places the vitreous strand can move. So you saw me here, I just isolated the vitreous strand, brought it to the center, and I'm using my cutter. This cutter was in the cut IA mode. Now I have gone to the IA cut mode. I'm using it like an irrigation aspiration instrument, holding the cortex, bringing it to the center. And if there's any attached vitreous strand to it, as I cut it, there's a vitreous strand attached to it, it got cut with the cutter along with the cortex, right? So, the dissection becomes so simple. See this, hold the cortex with the cutter, it comes to the center, cut it, and I've removed half the cortex. Now the next challenge, I don't want this rhexis to run out or this tear to run out. So I'm doing what is called a posterior CCC. That means I am rounding off the edge of the tear so that it does not spread out further. For here I need three things. I need retroillumination total, I need a higher magnification and a higher light. So I've rounded off one edge, the other edge is still there which can run off to the periphery. The ACM is maintaining the chamber. You can see this little notch here. This means there is a vitreous tag here somewhere. ठीक है ना? So I tackle this tag here. You see the tag there? The tag, either you cut it with a cutter or as you detach it from this area, from the port, it just sinks back. Now there is no stretch here and I am rounding off the second part of the tear. So, second part rounded off, now you are safe. Now this rexis is not going to run out further. Now, if you have sufficient posterior capsule, like we had in this case, you can put in a PCIOL. If not, you would have done a different IOL. Okay. So let's see this, another similar situation. Another similar situation, ACM is there in position, IOP of 18, cutting out, holding out the cortex with the IA system with a cutter, removing it. Here, now there are strands attached to this, so I cut it out with the attached vitreous strands. The torn edges are not running out because the chamber is not too, the IOP is not too high. Now again, you see what I am doing. I've increased the magnification, increased the illumination, total retro illumination. I can identify and hold it with a 25 gauge micro rexis forceps. This is not a 23 gauge. 23 gauge will not give me so much of a flexibility through a side port which is 1 millimeter in dia, 1 millimeter size. So I need a 25 gauge micro rexis forceps so that I have some flexibility to move it in the eye. The two edges are rounded off, I am safe. Again, I could put the lens in the bag, but I wanted to demonstrate here that I am putting the lens in the sulcus. Again, no visco. This is under fluidics only. No visco, because now the visco will drop in the vitreous and cause a late rise of IOP. So I put the lens under hydro, first open it up over the iris, then dial it under the iris. So this is in the sulcus. This is what most of us normally do, right? PCR, vitreous, you do a little vitrectomy, you put a lens in the sulcus, and that's it. And then we should do what we are doing here, an optic capture. That means I've captured this edge under one side, the other side. You can see this notch here, which is showing कि यहाँ पे haptics है, इसलिए यहाँ पे capture नहीं हुआ. This area, the optics have gone behind the rexis margin. This area, the optics have gone behind the rexis margin. Now you have a continuous diaphragm of the capsule and the lens. So vitreous can never come up. So you don't need to make a peripheral iridectomy here. ठीक है ना? Continuous diaphragm and the IOL is stabilized in the center. A perfect situation. So let's take another situation. A PCR, the same steps. So it is not very difficult once you understand these steps. The same steps, use an IA system to remove the cortex, identify the rent behind. This rent is not spreading out because the IOP is controlled. Again, the same technique, side port, I am rounding off the torn edges. So it is not just a fluke. You can actually round off the torn edges so that the rexis does not run out. And then if you have sufficient posterior capsule, say 50% or more, then you can put a lens in the bag. So here I had sufficient posterior capsule. So I'm putting a a normal IOL which was designed for in the bag implantation. The same lens I'm putting in the bag. I'm not worried about it sinking. But still, it's a soft lens. It can fold and collapse at times. So I'm going to show you something very good. A reverse optic capture. So now instead of pushing the haptics back from the sulcus, I'm going to lift up the optics from the sulcus and bring it over the anterior capsule. See that? A three-piece IOL, I'm bringing the optics over the anterior capsule. The haptics are still in the bag. And now this is very firm. You made a full capsule lens diaphragm, preventing the vitreous from coming up. You can see this here. You can't touch the anterior capsule here because it is behind the optics, but you can see this stretch area here where the haptics are in the bag, right? This can even work in larger lens. This can even work if you have a toric IOL. So this can work if you are doing a PC IOL and you don't have a backup 3-piece IOL, but your rexis is made. You can put the lens in the bag, keep it under control that it doesn't sink, and immediately pick up the optics and do a reverse optic capture. Right? If you have a toric lens and you can't have a backup for a toric lens, then what do? In a toric lens, you can use the same technique, dial it into position and lift up the optics so that you have a toric IOL single piece in position and you have saved the situation by a reverse optic capture. So the reverse optic capture is a marvelous technique. With this, you don't need a backup 3-piece IOL if you can master it. Let's see another situation. PCR with a planned toric IOL. Now, in this, the PCR is huge. I had a planned toric IOL. The rexis is run to the periphery, full on. There is no scope of rounding off the edges. I still have a toric IOL to place. Now what do? So this is the axis where the toric IOL is to be placed. Can I still place a toric IOL here? I just told you I can put the lens in the bag and do a reverse optic capture. Let us see how this case goes. I'm trying to put the lens in the bag. Lens is being injected under hydro insertion, no visco. Remember, if you are doing a hydro insertion, you need the tunnel opening to be a little more than what you would need in a visco insertion. So if my incision was 2.2, I have made it 2.8. I open up the lens, a toric lens you can see, over the iris. Then I bring it under the iris over the anterior capsule. And then I'm trying to put it in the bag. So the optics is going in the bag now. Right? But at the moment, my toric axis is not aligned to the axis that I want. Right? So I have to rotate this lens. The only one big mistake I made at this point. I'm trying to rotate it against the nature of the lens. I'm not rotating it clockwise, I'm rotating it anti-clockwise. My big stupidity, my disaster, and I had to pay the price of it. And Dr. Alka was in that OT on that day. Fortunately, we had a retina specialist in the next OT working on it. हमने कहा यार लेंस निकाल के दे दे वापस. So उसने लेंस निकाल के वापस पोजीशन पे दे दिया. Now, should I again go into the bag and do it? At that time, you're so tense. You said, यार एक बारी से पंगा हो गया, such a large rent. Let us put it over the anterior capsule and do a reverse optic capture. So we put it over the anterior capsule and did a reverse optic capture. That also works. Which means we are afraid कि यार उसका तो haptic का size छोटा है, it will not hold to the periphery. You don't need to hold it to the periphery. All you need is one optic behind the anterior capsule, one haptic in front of the anterior capsule, holds like a clamp. ठीक है ना? It's just holding like a clamp. So even if your haptic, we had one case where the haptic got broken. It didn't make a difference. We still put it in the AC over the anterior capsule and did a optic capture and the toric IOL was still in position. So you don't need that peripheral support in an optic capture. So I'm giving you some real unique ideas. They could work for you in some very tricky situations, right? And I'll give you just the second part of the presentation, which is what happens if you have a residual nucleus. So I'm showing you with PCR with the residual nucleus. I'll make it short. So we use what is called a lens scaffold, right? So what does this, how does it work? So now suppose you were removing this matter, and suddenly you see what you didn't want to see, a bright orange area behind. The rexes run to the periphery. You have a full tear, and you are afraid that your nuclear pieces are now could drop into the vitreous, and then you would have to cut a sorry figure, send the patient to the retina specialist, vagara, vagara. Can you avoid this catastrophe? Can you still manage it? Let's see. We have designed a lens. We have called it the C7 lens. Previously, it was just a contact lens, bandage contact lens, but now we have more specifications on it, which I'll talk about it later. And under hydroinsertion, you can put this lens over the iris. The size is 9.5 millimeters. It opens up, concavity up. Concavity is facing up. It opens up over the iris. You have already pushed all these nuclear pieces and debris to the side on the iris. This lens opens up, and then you guide all this nuclear debris onto the contact lens. Even these thick cortical pieces onto the contact lens. Now there's no risk of this debris falling in the vitreous. You take in a phaco probe and you just eat it up comfortably at leisure. All your pieces are in your sight, in your control. They are not falling back. Removed all these pieces. Fine. You are still under anterior chamber maintainer. Any small pieces on the sides, you can engage it with your iris, with your phaco probe, bring it to the center, take it out. Now you're only left with some cortex. With any forceps, this is a McPherson's forceps, you just hold it and pull it out. It's so simple. The ACM is maintaining the chamber at all time, and you can do your normal activity. That means you can remove it. This time, because there was no vitreous, I could just do a simple IA and remove all the cortex. Had there been a vitreous, I would have used a cutter and done a similar job. So, no vitreous, and you can just comfortably put in an IOL, right? After this, I'll just move on. So, now, what is important for all of us to understand? Previously, we had what was called the IOL scaffold. So, if there's a PC rent, you put an IOL behind the iris or in the bag, let the pieces come on it, you remove it, right? But the IOL in the bag or behind the iris, you don't have access to the cortical material behind it. You can just put it in. The central area is clear because it's a rent. The cortex is at the periphery entrapped. You could still work. But yes, if you have an option for a neater removal of all the cortex comfortably, it could be a better idea. And the second thing is, the lens is very thin, just 120 microns and concave upwards. So there's a lot of space between the lens and the endothelium. So this is more endothelial friendly than a biconvex IOL. So we prefer this lens in this situation. And this was the first post-op day of this patient. Cornea is absolutely clear. And endothelial cell loss, in this operated eye, it was 21, 24. Unoperated eye, 24, 74. So we say about a 10 to 15% endothelial cell loss. And everything is just how you want it to be. So now, for the first time, we have got it commercialized, because if you put a lens in the eye, it's a drug. It's a drug, no? If it's going into the eye. So there has to be a drug license, etc., etc. So there is one company which has started making these lenses, so you don't have to really wonder where I'm going to get these lenses from. So you just pick up a lens, open it and put it in the eye. So we have what is called a PCR kit. Thank you.
Thank you so much, Dr. Sanjay. That was truly a very, very a clear and a comprehensive talk on various situations of PCR with nucleus, with cortex. Very well showed. So one question, you were mentioning about the IOP at 18 and Eyelid of 24. But on the screen, it was showing us an IOP of 30. That was a different situation? Or?
Yeah, so this was that video when we used to keep an IOP of 30 in the Centurion system.
Correct.
Now the Centurion system, you can keep an IOP of 24.
Yeah.
That's the minimum it goes. 20 tak bhi chale jata hai, haan. Yeah, 20 chale jata. So now we started using that level now.
Okay, so you found a difference between 30 and 20?
The churning up effect you expect is less. There's more stability. So we are getting an IOP from the bottle and the phaco system at 18 or 20, right? So at all times you are at 18 and 20. So that makes a wonderful combination. And there's always a concept that people, that if you're adding one IV line at 18 and one IV line at 20, so the net pressure will become 38. It does not. You add 1, 2, 3, 4, 5, all are 20, the pressure will be 20. And the moment the pressure goes over 20, your infusion will stop from all the lines. And the moment it falls to 19, the infusion will start from all the lines. But the maximum pressure will go to 20 if the bottle you have adjusted or the phaco you have adjusted, the maximum IOP it is maintaining is 20. Right?
Can I add something?
Yeah, sure. Yeah. Yeah.
Dr. Rohit? Can? I want to add some sentences.
Very good question. So if you are doing a reverse optic capture, you are again in the bag. So the IOL power stays the same. When you're doing an optic capture, the IOL is in the bag. When you're doing a reverse optic capture, it comes up, but the bag collapses. So your power is more or less the same or 0.5 less. Right? Now the issue is that if you've done all that and you still have a single piece IOL and you promise that patient that lens, you won't have a backup of half there lying there. You can comfortably use the lens. Now half will only reflect as 0.3 in the overall outcome. It is about 0.3, which is insignificant, so patient doesn't feel anything.
But you can keep an armamentarium of 3-piece and iris claw ready for all patients, ideally.
So then, now this is the situation which I have told you, where we can use this technique. But then some people may have more difficult situations and you may not be able to use these techniques. So my colleagues will tell you of the other situations, how this is to be managed. Kiran, you had a point?
Yeah.
And then I can ask Dr. Anaga to give her way of managing when things go beyond a certain stage.
So I am going to tell you about my thought process. My thought process is that we are taught about making a rhexis which is 5.5 millimeters or 5 millimeters, and that has become our religion now. Whether you have a posterior polar cataract, whether you have a black cataract, we are bound to do that rhexis of 5 millimeters or 5.5 millimeters. But this is not the case. This should not be the case in every cataract. Dr. Rohit is behind me also. He supports me. Yeah.
And on the side.
Side. So when you have a posterior polar cataract or you have a black cataract, there is no need to do a round rhexis. You should not be fanatic about it. Do oval rhexis. Oval rhexis will help you make a very it will give you a very big area to work in. and you can make very long and deep gutters which are easy to break, and you can easily bring out the segments in the interior chamber and eat them up. And the very reason Dr. Chaudhary dropped the IOL in the vitreous was he was struggling with the leading haptic. He was trying to push it down the interior capsule, but because it was round, he was unable to rotate it inside the capsule bag. Had it been an oval rexis on that side, he would have easily done the in the bag implantation. So the other point is, all the cases except the last one which he has shown all cases were of posterior polar cataract, and he was expecting a PCR and he was pre-prepared for all this. That is why he had put a Chaudhary irrigating cannula inside the interior chamber, and it is a good way of stabilizing the interior chamber, no doubt. But if you don't have that cannula, you can do the interior vitrectomy and fill the interior chamber with viscoelastic, and then do a dry aspiration with a 27 gauge cannula attached to a 1 cc syringe which has been previously flushed with a viscoelastic to increase its vacuum or suction power, so that you don't misfire while you are aspirating the lens matter from the corners of the capsular bag. And if you have oval rexis in such cases, it is very easy to aspirate from every nook and corner of the capsular bag. And when you have a round rexis, in cases of PPC, when you try to go behind the interior capsule, you usually you bounce against the vitreous, and it is a vitreous which comes into the 27 gauge cannula. So I'm not taking much of your time now.
Sir,
Okay. So
Shall you come to the discussion on this
yeah,
later?
yeah, yeah.
After the talk?
So
Huh?
yeah,
Sir, do you have any suggestion about the long diameter of the oval rexis you are suggesting?
yeah, yeah.
Should it be horizontal or vertical?
It is.
Should the long diameters be towards my main pole or
Yeah, yeah.
towards my
Long should be towards your main NCN.
Okay, so we'll take this discussion at the end, because there's so much to discuss in a PCR. So I have the privilege of welcoming Dr. Raghuraj, and Dr. Naga will talk to you on a situation where there is no posterior support, and you are you still have to salvage the position, and you have a backup lens. It could be a 3-piece IOL, or it could be an iris claw. An iris claw is gaining a lot of popularity. It's easier to do it compared to a still fixated lens. So, and even Kiran here has a lot of experience with the iris claw lenses. So this would be a wonderful platform to discuss about these lenses. Another, over to you.
Thank you so much, Dr. Chaudhary, and very good afternoon to everyone here. At the outset, I would like to thank Dr. Sanjay Chaudhary sir for inviting me here for this talk. So basically, if you look at the history of the iris claw lenses, you had iris claw lenses which were in the anterior chamber also, but it was Brass and Nohan who modified this technique, and they fixed it to the posterior surface of the iris. So the better advantage is that it can help preserve the corneal endothelial cells, and remember that the A constant is altered accordingly to 117. So when would you use a retro-fixated iris claw? First and foremost is there is no capsular support. Definitely if you have some kind of anterior capsular support, you would, there is no anterior capsular tear, you would first prefer to use a 3-piece IOL. But in case there is an anterior capsular tear, there is a large PCR, or there is a total bag which has come off, obviously you have no choice. So in such conditions, retro-fixated iris claw works well. Now, secondary IOL is also a condition where there is a patient has come to you with aphakia, and you want to put in, give him a correction with an IOL, so the secondary IOL, or the IOL that has been put in the eye has dislocated and you want to do an IOL exchange, so the entire capsular bag has fallen off and now you have to treat the patient. So what are the principles of treatment before we even go on to the surgery? Prior planning, you need to understand what the patient is, take a slit lamp photograph of the patient and plan how you're going to do every step. Before you even take up the patient for surgery, in case of a planned, either an IOL exchange or a planned in aphakia case, a peripheral retinal evaluation to rule out any kind of pre-existing retinal tear or hole, perfect biometry. So whenever you are doing any case, suppose you have a high risk case, suppose you have a very high subluxated cataract or a hard brown cataract or a very small pupil, wherever you feel is a very high risk that you might need a iris claw, you do a proper biometry and see that the A constant is adjusted. So select the lens properly. If there is a planned case, then specular biomicroscopy to look for the corneal endothelial status and OCT macula in these cases. And as I said, in all high risk cases, you keep a standby 3-piece IOL, claw instruments, diluted tricot, vitrectomy, everything ready, and counseling of the patients also. So coming to the surgical principles. Now, because this involves enclavation of the iris to the claws, definitely it can cause pain. So these patients prefer to do under peribulbar block. Another thing is how much incision would you do? I'll show you a lot of cases. So if you're making a sclerocorneal tunnel, it should be at least around 5.4 millimeters. Side port should be ideally at 0-180, that is 9 o'clock. And the more direct it is, it's better. If you make a very long tunnel, it's difficult to maneuver the side instrument and it can act as an oar. So it restricts the movement. Always check for the capsular support. We had a case where there were a lot of capsular remnants there. And then if you try to put in an iris claw, there is no place or it can get tilted. Look for proper iris support. If there is no iris support or if there are iris defects or atrophic areas, avoid those areas. Check for presence of vitreous. You have to see to it that there's complete vitrectomy done, anterior vitrectomy, posterior vitrectomy as the case may be, and only then go in for the lens. Now, neither you should have a very small pupil nor a very large pupil. If the pupil has been dilated or if it's dilated because of a peribulbar block, then put in a little bit of pilocarpine, and normally it should be around 4 to 5 millimeters. If it's too small, then when you're maneuvering, it can cause a sphincter tear. Use the right OVDs to keep the chamber formed and avoid sphincter trauma while enclavating the haptics. Now, you have a lot of companies which will give you these iris claw lenses. They are all PMMA, either biconvex or convex concave, with an IOL diameter of around 7.25, 8, 8.5 or 9 millimeters. So how important to know, why is it important to know what kind of lens you are using? So if you are using the older biconvex configuration, remember there is a chance of a pupillary block. So you'll need to do a PI. But the newer lenses are convex concave and with the concavity oriented superiorly, anteriorly. So here you need not do a PI. So that's why it's important to know which kind of lens you are using. This has a better safety profile. What contraindications are there? So obviously if there is an aniridia, there's no iris support at all, rubeosis iridis, lot of iridodonesis, active uveitis, obviously these are cases where you will not operate. So this is just a small animation to show. So here you have made 2 side ports at 0-180, main incision, check with diluted tricot, do a complete anterior vitrectomy, and then put in a little bit of pilocarpine, keep the pupillary diameter at 4 to 5 millimeters, use the lens, check the patency of the claw every time before you put it in the anterior chamber, rotate it horizontally first with the 2 Sinskey hooks, hold it with a tight and nice grasp, and then on both the sides you can then tuck the iris through the claw, enclave the iris, and you are done. So let's see a few cases. Now this was a patient where there is a dislocated cataract. So here first of all we are doing a 3-port posterior vitrectomy, managing with the phacofragmentome the cataract. Once this is done, then we will have a condition where there is a aphakia now. So now we are putting in viscoelastic. I've made a scleral tunnel, as you can see here. The pupil is nice and round, and now we are using a iris claw. So we are first checking for the patency on both the sides. Put it in the anterior chamber. See that the chamber is well formed. You can replenish it with visco. Rotate it to the sides where you have made the side ports. Grasp it well. Put in the left side. You are using the iris claw instrument to just tap on the iris so that you can enclave it. So you have to have it ready even before you bring the iris claw, the claw below the iris. So see in my right hand, that rod is ready. Then with the left hand, grasp it well, bring the claw towards where your instrument is, feel for the notch and then just dip the iris. So you have done it, and then you can suture the main incision. This is another case where it was a old case of pseudo exfoliation, and you can see the entire lens capsular bag is moving and is subluxated, which will have to be removed completely. So again a scleral tunnel is made, and in order to facilitate bringing out the iris, bringing out the entire capsular bag with the lens, we are putting in viscoelastic and bringing it out very gently. The entire capsular bag with the lens comes out, doing in a thorough vitrectomy, checking with diluted tricot, see that there are no vitreous strands. Again, taking in the iris claw, check for patency each time. There have been cases where it has not been checked and then you are trying to push in the iris and then it doesn't. So then you are faced in a situation where it's enclaved on one side and not on the other. So this should not happen. That is why you have to check it outside. So then fill in the chamber with viscoelastic, grasp it well, and then with the rod on either side, you can just enclave the iris on each side. So where to enclave is also important. It's in the mid-peripheral area. If you are very close to the pupillary edge, then it can cause a ovalization of the pupil. So this was an interesting patient, a patient for trauma. There was not only subluxated cataract, but also you can see that there is an iridodialysis. So you have to treat both the iridodialysis as well as the subluxated cataract. So first we have made a scleral tunnel 1.5 millimeter away from the limbus in the area of the iridodialysis, and using a railroading technique with a bent 26 gauge needle and a 90 double-ended nylon straight needle, we are first treating the iridodialysis, suturing it, and then tying the suture so that the knots are buried in the tunnel so that it doesn't irritate the patient. So the pupil is nice and round here. Now the second challenge is removing the dislocated cataract. So we are making another tunnel temporally, because superiorly already there is a tunnel where you have sutured the iris, so that cannot be used. So now we are removing the dislocated lens, doing a vitrectomy here, and now you have to treat the patient with, you need to put in a lens. So this was a patient of trauma. So there was a traumatic mydriasis also. So we are trying to put in pilocar and see, pupil is not really very small, but it's enough adequate support to put in an iris claw. So again, on both the sides, we have managed to put in the iris claw. This is another case where, again, there was a dislocated IOL. So it's an old patient who came back to us. So here again, we have made a scleral tunnel, putting in a 3-port. And then you can see down how the IOL was dislocated. So first you need to bring that out, do an IOL exchange, remove the old lens. As you can see, this is the single piece Rayner type lens. If it was probably a 3-piece, then you could have probably made it as a glued IOL or a Yamane technique. So once this is done, constrict the pupil, put in viscoelastic, and then similarly as we have seen earlier, put in the iris claw lens. Rotate it, and then on each side you can just dip in and enclave the iris. This was another case where you can see how the IOL was dislocated, but you can see the haptic in the inferior area. It's best to do these 2 side ports first and then open up the main incision. Bringing out the dislocated IOL first through the scleral tunnel, and then you can put in the iris claw. So these are complicated cases where already there is a procedure of removing the dislocated cataract or the lens. So in such cases, this retrofixated iris claw is a very quick technique which will reduce your surgical time. If you plan a glued IOL or a Yamane, it will involve even more manipulation, maneuvers, and surgical time might increase, especially if you are a beginner. So this was a very interesting case, cataracta nigra, a very hard black cataract, and there was a lot of phacodonesis. So otherwise we would have planned an SICS for this patient. But see, we have used a very old technique which we were taught in our residency of cryo. So we're just opening up the incision using the cryo, but it's a very clean technique. There's no vitreous loss also. You can see how black the nucleus is, a very large one. So it would have been probably phaco or a SIC, because it was a very, there was phacodonesis, we planned to do this technique. And then putting in an iris claw. So I think for want of time, I'll shift to some struggle. So this was an interesting patient. This is my last video, where, see, where you can have difficulties while putting in the iris claw. So here I am doing the same steps, put in the iris claw lens inside, pushing in viscoelastic, and I am dialing it horizontally. But when I am holding it, this was a forceps which was a little older one. So it was, the grip was not right. So look what happens. When I am trying to enclave, suddenly the entire forceps tilts on itself. So the grip is not right. It's very important to have the right grip, a forceps which has a proper grip. So I changed the forceps and tried to enclave again, but see what happens again. And another thing is, I didn't have a third forceps. So now what I've changed is, look at the tip of the forceps. It's beyond the edge of the diameter of the lens. So here it gives a little better grip. So now I'm able to do it. Now on the right side, when I'm trying to do the same thing, I enclaved it, but I was not very sure. So you have to see the dimple very clearly. If the dimple is not clear, it means that the enclavation may not have occurred. So that means on the next day you might have one edge or both edges of the lens down. So here on the left side the dimple was seen, but the right side it was not seen very clearly. So I went in with the irrigation aspiration to see whether the lens goes down or not. Don't leave it for the next day, otherwise you will have a dislocation of the lens again. So we bring it up, enclave it again, and then you're fine. So this was the same patient next day post-op. So you can have certain complications like pupil ovalization, redislocation due to improper enclavation, raised IOP, endothelial cell loss, CME, and it's not an US FDA approval done for treatment of aphakia. So this was a literature overview, and advantages is, as it's a simpler procedure, shorter learning curve, can be done by an anterior segment surgeon, no issues with the sizing of the IOL, and it centers well on the pupillary axis, and no damage to the angle or the iris root, can give good functional outcomes. Thank you so much.
That was really good.
Dispersive viscoelastic.
2-3 quick questions before Rohit takes over. What lens do you use? What forceps do you use?
So we have used two kinds of lenses. One is from the Care Group, and one is the XL lens.
So these
XL.
ones with that?
XL, yes.
These are XL. Okay. What forceps do you use?
So this
Whose
forceps was iris claw forceps. It has two, one on top of the other. So it will hold it like this. But there are better forceps where you have a horizontal T kind of forceps. So that has a better grip.
Clayman forceps.
Yes. So that you can hold in the center of the lens, and it has a very good grip because it has a very broad central T.
So where do you get that forceps?
So you get it through Abhinandan.
नहीं एप्सिलॉन से मिल जाता है.
Epsilon also.
Clayman forceps.
Right. Thank you, Naga. So there's a lot of questions we have to ask you on this. So let Rohit also
Yes.
have his talk, then we'll have a general discussion.
Yes.
Come join me here. Thank you so much. And Rohit, we're looking at you to give us a clear idea about this project.
There's never anything clear.
In PCR.
The absolute is only he. Clearer. Yeah.
So fluidics is very important to understand,
absolutely,
because
absolutely.
all
Yeah.
this is easier to show, but you really have to, the whole game is in the mind.
Yeah.
The whole game is in the mind. Even FACO, we say the game is in the mind. You're playing the game there, but every step is working in the mind. So if your clarity at any place is wrong, you tend to make mistakes. You can only handle a mistake if you know the basics of the system. Then you know how your machine is working, you know how your hand is working, you know how your instruments is working, you know how the fluidics is working, you know the whole, how the dynamics is working. So Rohit will tell us about the dynamics.
Yeah.
Over to you, Rohit.
Thank you, Dr. Sanjay sir. So I would like to thank you for inviting me over to your IC. So I'll be taking up fluidics in PCR. Well, PCR does happen. We know about the signs of PCR. We know that there should not be any panic mode. We know that there should be chambers, stable chamber settings. We need to evaluate what is the situation. We have to strategize. Then we have to use triamcinolone, do anterior or posterior vitrectomy. Well, let's go through a few cases to really understand what my perspective about things is. So this is a patient who has a fibrotic cataract. The left eye is pseudophakic with optic capture. Most probably had a PCR. So that makes one, wary of the fact that there may be a posterior polar cataract or something associated with it. So I did a flax in it, made it slightly smaller, because in an event of posterior capsule rupture, I may be able to do an optic capture. So let's see how things shape up. So things have started. Now after doing the capsulorhexis, I've created a small valley, and then when I chop it the way how our Dr. Abhay Vasavra has taught each one of us to do multi-level chopping. So that is being done. So then I rotated. This is being done at a higher speed to afford better, visualization of important step. And while making a complete separation, I was happy that I was able to do it. And suddenly I realized, which you would also, that there's a PCR behind. Now, what next? Well, the only thing is now there's a change in surgical plan. I have planned to reduce the IOP to physiological settings. I would not be rotating the IOL. I would be doing slow motion phacoemulsification, use IOL as a scaffold, do supracapsular emulsification, IOL capture, toric IOL depending upon the situation. So the fluidics which I would be using would be, as Dr. Sanjay has already explained quite a bit to make my life very easy. So in this, what is going to happen is that I'm going to use around 20 IOP, which boils down to 27 centimeters of bottle height, and the flow rate is going to be 23. So this setting has, each one of us should practice before we really, apply it. When I say you have to practice, it doesn't mean that you have to create a rent and practice it. Each one of us is using higher fluidics. We have to titrate it down to lower settings by making it 40, then 30, then whatever it is, and then graduate into it. So, and active fluidics, if you can incorporate, nothing like it, because these active fluidics is better than the reactionary or the gravitational one, and slow motion phacoemulsification. Now, what is this low IOP or a physiological IOP going to do? Then your anterior hyaloid phase is not going to continue as your foe. We are going to transform it to an ally. So how do we do that? Let's see. So in this patient, the IOP and everything, as I've explained, is there. So the first thing which I'm going to do is I'm going to pull it out. Now what is happening in this situation is that there is less influx of fluid. With this less influx of fluid, what is happening is that there is less posterior bulging. As Vasavras have shown it, that with high IOP, with an intact posterior capsule, you can still have rupture of anterior hyaloid phase. So with this, what is going to happen is the vitreous is not going to hydrate, the anterior hyaloid phase is not going to rupture, and you will find that the capsular remnants, the nuclear remnants which which are going here and there will not go behind. Now I am caught in a very bad situation because it is subencinal. Did you see the striae? This shows that it is not fully inflated. Now a small trick which I am going to use is that I am going to move it slowly, gingerly, so that the moment I am able to cross that, then I will use IOL as a scaffold. I'll pull it out, chop it, so that I have a smaller piece to work and lesser chance of it hitting the cornea, and then emulsify. And then once I've emulsified, I'll use IOL as a scaffold. With the IOL as a scaffold, you can go at a deeper plane. The IOL acts as a posterior capsule. It doesn't allow the nuclear fragments to go behind, and you can continue with emulsification at your sweet will at a deeper plane, very close to the posterior or to the artificial posterior capsule, which in this case happens to be an intraocular lens. Fluid stable chamber setting, and the case was completed. So this is another situation. We have this patient had a moth-eaten appearance. So Kiranjit's oval rexus is being done. So sculpting is being done. IOP is still 34, and now at this stage I'll be chopping it. Once it is chopped, what is the next step? The next step is going to be cross chopping, because I do not want by any means to rotate the nucleus. Once you have cross chopped, then you can take it out, and once you can take it out, you can feel that the low fluidics are not creating this, are creating the same situation, total separation. Dr. Sanjay, how did you like this backflip?
That was very unique.
Did you see? Yeah. This is only possible if you have done your oval rexus. You see how you go, you separate it and backflip.
Right.
With this backflip, you can just make it forward, come forward, and the IOP here now is 20. So now you can use chopper as a shield also at times if it happens to be a harder cataract, slow motion phaco, and with these parameters you can go ahead. I would like to show you something very interesting. Here I am going to chop it, and once I chop it, because I did not want to rotate it, so here slow motion, just see what is happening now. These are the 3 nuclear small fragments with IOP 20, with the shield, mark my words, of anterior hyaloid phase. They are going to go there and bounce back. How I feel, anterior capsule, this anterior segment OCT could have caught it. It's going, it is not going back. It is hitting it, and it is coming back. So, you will not lose even a small nuclear fragment for that matter. And it is continuing. This is only possible if you use, if there is no pressure difference, if there is no turbulence, if the chamber settings are very stable. Stable chamber settings, and then you will find what is happening is, you do IA and everything, yes, and visco express it out, one of them will come out easily, the second wants to, but it will require more effort, so I'll take it out afterwards because I'm sure. So this is the dry aspiration which you would have seen my father do, in those days, the Wells Gills technique, which is now being, carried out all across the world. So irrigation, aspiration, fix, tease and strip, and that is taken out. I'll put the lens, this nuclear fragment, you will feel that it is still there. The IOL will go in, the third fragment is somewhere here, and it has come out. So reducing these fluidics makes hell of a difference. I think we have paucity of time, and I've finished it in 7 minutes. So basically, there are so many cases around which I can show if you feel. This is another one, and I can show you another case, of a phaco punch. What has happened is, where is that? So, even with a phaco punch, you can create a situation where you can take it out, the whole nucleus, with the whole nucleus present, and without it falling behind. I think I should close. Thank you very much for your kind attention.
Thank you, Dr. Rohit. Come join us and we can have some discussion.
Yeah.
So, Dr. Kiran, you also into a lot of iris claws. Yeah. Right. And Anaga, you also into iris claws. You both have extremely good experience into all these. So, in the current scenario, if you have a PC rent and the posterior capsule support isn't much, should it be an iris claw or should it be a scleral fixated lens?
There is a movie on by Dr. Jan Wust on the internet, YouTube, in which he has injected so many dyes in the cadaver vitreous, and he has seen that vitreous is not just jelly, and it is actually has got a structure, it has got a character, it has got channels, cisterns, and whatnot in the vitreous. So they are meant for the nourishment of different parts of the vitreous cavity or the retina, like you have bursa premacularis. And if you do a lot of manipulations in the anterior chamber, those agents go back and cause CME. So vitreous is not to be cut like that only, it has to be respected. So whenever you are doing a glued lens or Yamane, you are disturbing the vitreous, and moreover you are putting traction on the vitreous strands, which ultimately get transferred to the retina and cause holes. So one of the persons who is actually doing a lot of glued lenses or Yamane, he has given me this big list of complications associated with these lenses, SFIOLs. So iris claw lens, in that you don't disturb the vitreous as much. And this two claw iris claw lens is very, very stable. And as far as ovalization is concerned, it happens only when the pupil is not properly constricted, and number two, when the IOL is of bigger size. When the IOL is bigger size, you tend to enclave the pupillary side of the iris into the claws. That is the cause of ovalization. So you have to keep the size of the lens 7.2 millimeters and not 8.5 millimeters, which IOCare I think it is 8.5. It is too big a lens, so it should be 7.2. You will never have a ovalization. So, and very lately, I am.
Can I ask you one quick question? You said this is better, and you see a lot of problems in the Yamane.
Yeah.
Give me 1-2 quick ideas. What are the problems in Yamane?
I haven't experienced myself.
Whatever you read about.
Yeah, it is IOL tilt, then extrusion, intrusion, vitreous hemorrhage, and traction.
Extrusion, intrusion of what?
Of the haptics, those beads.
It breaks through the conjunctiva.
Yeah.
And gets exposed.
Yeah, and there is scleral necrosis also, and then you can have endophthalmitis also.
So, how many cases of endophthalmitis have been recorded? Any idea, Dr. Naga, with Yamanis?
Basically, it involves lot of manipulation and maneuvering, whereas in the retrofixated iris claw, it's a very quick technique, and the maneuvering and the manipulation is minimal. So that is why definitely the risk of endophthalmitis or posterior segment inflammation to CME is much lesser. So like he also said, definitely if I have to choose between an SFIL and this, then this is
will be better.
and it's quicker. So like all these, already if you have had a PCR or if you are doing an IOL exchange or a dislocated cataract, it's already a complicated surgery. The corneal endothelium is at risk. So we don't want too much manipulation, we want a quick surgery.
So is there always a fear that since the haptic is coming out from inside to outside, that whenever there is a conjunctival infection or a purulent infection, that infection could travel down the track of Yamane's technique and cause an endophthalmitis? Yeah, right. Is there a fear of that? Last question. Yeah.
Not in every case.
No, but is it always a fear that that infection can always travel down because there is a tract there, or does the tract seal?
No, it keeps on moving, and that is the cause of scleral
Necrosis also.
Necrosis
So always a fear is there.
Fear is here.
That you have a tract there. So it's always better to have your things within the eyeball and not crossing over, right? Right? So I think it's time to hand over. Thank you so much, Dr. Kiran. Thank you, Anaga. And thank you, the audience. Yeah, it's for you.